this is me. And for those that have seen me present before, I hate talking about myself, so I will leave this up just a few seconds and then go on to the content, which is much more interesting. I'm going to talk about targeted moments of environmental disinfection as a methodology to help address the risk of AMR and ultimately to impact HAI rates. I'm going to talk not about any of the products that my company sells, but I'm going to talk more specifically about an approach and a methodology that you can use. And I'm going to talk a lot about the literature around the risk of the environment. There are, I think, several key questions we want to answer. And after I get through the agenda, we're going to jump right into the first one. The first question is, how strong is the evidence that patients get pathogens transmitted from their environment that ultimately results in an infection? And the data is increasingly strong, but apparently I decided to do the issue slide first. So my apology, I reversed them in my mind what I was going to talk about first. So when people ask how big of a risk is AMR and how much from a resource perspective should we be putting towards it, I thought it was helpful to put together a couple of slides that include quotes from the WHO and the US CDC to give you some information that you can use in your discussions. Increases the cost of healthcare, lengthier stays in hospital, threatening the ability to treat common infectious diseases, prolonging illness, disability, and death, coming from the WHO. Without effective antimicrobials, certain medical procedures become very high risk. Also something I'm not sure we always think about when we think of AMR. Antibiotic resistance is one of the most urgent threats to the public's health. As bacteria become resistant, they become untreatable, leading to dangerous infections. Often the most deadly resistant healthcare-associated germ spread from patient to patient and across healthcare facilities through patient transfer. When not stopped, these organisms can spill over into communities, becoming much harder to control. Okay? And I put the link on the bottom for those that want to look up the papers that these came from. How can we stop AMR? What do the experts tell us we should be focusing on? Three main strategies: preventing the infections in the first place, slowing the development of resistance through appropriate antibiotic use, and stopping the spread of resistance when it does develop infection control activities. 5 core actions to prevent AMR: infection prevention and control, tracking of antibiotic-resistant infections, antibiotic use, vaccines, therapeutics, and diagnostics, and the environment and sanitation. And this slide is all taken from 2 papers from the CDC that are posted on their website. Why infection prevention and control? Without appropriate infection control actions, germs can spread to people from other people on surfaces like bed rails or the hands of healthcare workers. And bed rails is a particular thing that will come up several times in my presentation. We want to look at how many times people touch it, how many times people are in the room that have opportunity to touch it. These are numbers that when I first started working on this as a project about 5 years ago, I was really unaware of just how many times people touch bed rails. So I'm going to cover that in a little more depth later on. Germs can cause infections in the community when healthcare settings do not stop their spread. Not a surprise, I don't think, to anybody in the room. And now, as promised, we're going to go on to the evidence about transmission from patient to patient through the environment. There was a nice review article that was published last year. For those that didn't see it, it was published in the Journal of Hospital Infection by Wu. They reviewed a range of papers that addressed this risk of either prior patient or prior patient roommate. And when they did the analysis, this was a meta-analysis paper, when they did the statistical analysis, they determined the odds ratio was 2.69. So you're about 170% more likely, or almost 3 times more likely, to be acquiring certain pathogens if either the person in the same bed or the roommate in the same room had these pathogens prior. And these are organisms like MRSA and VRE and Clostridium difficile. So environmentally transmissible pathogens. The tornado charts on the right give you a sense of what the ranges were from the various studies. You'll see that there's a few that dip into the negative range where it might actually be protective to be in a room where the previous patient had infections. That doesn't seem particularly likely to me. But you'll see that all but a handful of the papers show a protective effect that a negative effect that it actually increases risk to be in a room where the previous patient had a certain infection. Now, because many of these papers are small, single site, only done in a particular ward, it's often very difficult to sort of translate that into a hospital-wide view. So this paper, which was done by Cohen in 2018, which I like a lot, they looked at over 6 years in 4 hospitals, almost 750,000 admissions. And what they found in their tracking was the risk was even higher than what's been reported like in the meta-analysis. Here they say the risk is almost 6 times higher when your previous patient had the pathogen, or if the roommate had it, it's about 5 times higher. So both of these present significant evidence, but we should note also that as genetic epidemiology becomes more prevalent, these studies in general don't look at the specific strain. One patient has MRSA, the next patient has MRSA. The implication is second patient got it from the first patient in some way. Healthcare worker hands, surface to surface to the patient. As techniques for analysis become better, we will see, and we are starting to see in the literature, that they're actually typing the specific strains to help us determine whether or not this is a true risk or just a composite risk that we're seeing for other factors. Now, because I'm going to talk about surfaces, and hand hygiene is really important, I always try to remember to put a slide in that talks about hands so that people don't think I'm ignoring it. Yes, of course, hand hygiene is very important. And if you saw John's presentation this morning, he's talked about some innovative ways to try to perk up programs, which I thought were quite interesting. Getting true hand hygiene to over 70%, I think, is a great goal. But we should also be thinking about this risk when we're communicating with staff. So what do we tell them the risk is? And I found these nice quotes from the WHO paper on their hand hygiene guidelines from 2008, 2009. During daily practice, healthcare workers' hands typically touch a continuous sequence of surfaces and substances, including inanimate objects, patient's intact or non-intact skin, mucous membranes, food waste, body fluids, and the healthcare worker's own body. So hands become contaminated frequently because hands touch a lot of things. With each hand-to-surface exposure, a bidirectional exchange of microorganisms between hands and the touched object occurs, and the transient hand-carried flora is thus continually changing. In this manner, microorganisms can spread through a healthcare environment in a few hours. So, what's the risk? Hands pick up lots of things because hands touch a lot of surfaces. There's a bidirectional exchange. You put down and pick up every time you touch a surface. And in doing that, organisms that are in one area can be transmitted around the patient environment and to other rooms and throughout the facility within a few hours. If you followed some of the work that Curtis Donsky's group is doing with the cauliflower mosaic virus, where they're putting this virus on the floor next to a patient bed and then going back 24 and 48 hours later to see how far through the hospital it spread, they're showing that there are mechanisms at work that are allowing organisms, even potentially from the floor, to get to off-the-floor surfaces and get all throughout the hospital. And while I'm not including that in the discussion today because I include that in a larger presentation on floors, I will just mention it because I think it's an important reference point. Lastly, hand contamination with MRSA has been demonstrated to occur with equal frequency when healthcare workers have direct contact with a colonized or infected patient or through touching only contaminated surfaces. So this comes from a study in Curtis Donsky's lab. The lead author was Stiefel. It's a few years ago, but I think the paper was really well done. And basically what it says is if you're a healthcare worker and you go into the room where the patient has MRSA, whether you touch the patient or just surfaces near the patient, you're as likely to pick up the organism on your hands, and you're as likely to pick it up in the same numbers. So there is no difference, statistically speaking, in risk, whether you touch the patient or you just touch the surfaces immediately near the patient. And that becomes important when other people enter the room and think that touching surfaces but not the patient somehow represents less of a risk. We need to be clear in our discussions that touching the patient or the patient's environment, anything within that patient's zone, same risk, and therefore should be treated the same way in terms of disinfection and hand hygiene. This is a study I came across. It was almost 3 years now. The lead author is Clacks. They had a brand new hospital open, and they wanted to see just how quickly the environment of the hospital and the environment immediately around the patient changed. Like, how does that interaction occur? Are patients becoming more like the hospital, meaning that they're picking up bugs from the surfaces, or is the hospital becoming more like the patient? And what they found was it's a mix. First, one of the, I think, most interesting insights, the antimicrobial resistant genes found in the bacteria, much more common on the environmental surfaces than on patient skin. So these resistant genes are getting into the organisms in the hospital, and they're forming this large reservoir, which makes it easy for patients to pick them up at a later time. it is probably, and I'll say probably, less the case that the patient is coming in with resistant genes on them already. Patient skin and environmental surfaces become more microbially similar over the length of the patient's stay. Okay? That's not really surprising. Bidirectional exchange. Patient has any mobility, they're up out of their bed, they're touching things in the room, they're picking up stuff. The healthcare workers come in and out of the room, they're transferring stuff around. And over time, these areas, the surfaces in the room and the patient's environment, they're becoming very, very similar, microbially speaking. Initially, the patient, the last one, the strongest statistical relationship, patient hands in the room floor. Now, I'm not sure I know exactly what to make of that, but I thought that was really significant because we have generally viewed the floor as very low risk, not worth anything more than perhaps daily cleaning. And it is possible, based on this and some other studies that have been done, that there is a higher risk. Now, what that risk is hard to quantify because there hasn't been a lot of research around it as far as I'm concerned, but I think it's interesting to note this study also talks about floors as having some relationship to surfaces off the floor. Because if the patient hands are getting it, unless the patient is down on the floor, there's some mechanism that's transferring these organisms up and then potentially back down. Initially, patient skin started to resemble the bacteria of the room, and then later, their bacteria were disseminated into the room. So initially, the funnel is going towards the patient, and then after a while, the funnel is moving away. They're contributing more to the environment than they're picking up. But in that initial period, 24 to 48 hours, they're picking up a lot of the things that are in the room. Bacteria in the room, especially the bed rail, consistently resembled the patient's skin microbiota. So at some point, there's an equalization where roughly the same types of organisms are present, and bed rail again shows up as a risk factor. Patients that were confined to the bed had a lower microbial diversity in their nose, hand, and the bed rail samples. Being ambulatory correlated with a higher diversity. Right? So if a patient can leave the room, they're going to pick up stuff from other places. Again, probably not earth-shattering, but nice to see that there was some documentation that this occurs. And then from last year, Blanco did a literature review as well, looking at the strength of the evidence, looking at the various pathways. So if a patient can get sick from these organisms, they can get it from the environment, or potentially from another patient, or potentially through a healthcare worker. And what they tried to do was summarize in this review article, what's the strength of the evidence for each of these cases? So I include that here because I think it's important when you talk to others to be able to say with some confidence whether or not there's strength in this evidence. I always put the references on the bottom of my slides, and as a personal thing, I always make my slides available for people that want them. You're welcome to take pictures as we go, copy down things, but rest assured, if you talk to Tanaz, she will give you the presentation. Okay? Just so there's comfort with that. If you see something you really want to follow up on, we will make it easy for you to get to these slides. From the patient to the healthcare worker. So does the patient contribute organisms to the healthcare worker? Yes. Strong evidence, consistent across a range of pathogens. Not surprising, but good to know that there's good evidence supporting this. Patient contributing to the environment. Strong evidence, again, consistent across organisms. So these two pathways from the patient have very strong evidence. They pass organisms to the healthcare workers they interact with, and they put them into the environment. Healthcare worker to the patient. Best studied for MRSA, but not so much for other pathogens. So one could argue that it's probably the case for other pathogens, but as scientists, we always put the footnote on. However, without studies showing that the risk is the same, we should just be cautious. The risk might be different for different types of organisms. Environment to patient, environment to healthcare worker. Moderate evidence, but mostly focused on MRSA. Same caveats. Environment to healthcare worker. Moderate evidence, consistent across organisms. And then lastly, patient to patient. Evidence strongest for MRSA, but varies across organisms. So other organisms have been studied. In the Modi study, the authors swabbed the hands and the nares to determine the rate of colonization and environmental surfaces to see if there was a link. So related to some of this previous work that I've summarized, this is a recent study that just was published last year that I thought was particularly good. They found 14% of their patients had at least one MDRO on baseline. Okay, so a patient comes in, within 24 hours they test the patient, 14% of the patients have some MDRO, either in their nose or on their hands. 10% had hand, 7.5% the nares, 3.5% both. And those are the people that probably touch their nose a lot. Of those colonized, almost 60% had MRSA, 36% had a gram-negative bacilli, and 14% had VRE. 29% of the environmental surfaces in patient rooms were contaminated at baseline, which was within 24 hours. So the patient's in, within 24 hours they come into the room and they do samples. What they found was almost 30% of the rooms showed evidence of contamination when the patient came in. Patient hand contamination was associated with room surface contamination. So the more patients have on their hands, the more likely the surfaces are contaminated as well. Again, not earth-shattering, but consistent from what we've seen in some of the other literature. There's a stepwise increase in contamination of both patients' hands and surfaces with longer times from patient admittance to study enrollment and room sampling. Now here's where I think it starts to get more interesting, because on a daily basis, we send environmental services workers, domestics here, right, housekeeping staff, domestics, we send them in to do cleaning once a day. Should they not be knocking down the level of organisms if they do the patient room cleaning properly? I would think so. So either there's a lot of cross-contamination occurring, the room gets cleaned, but then shortly after that it gets recontaminated, or the room isn't being cleaned properly, or there's some third mechanism that I couldn't think of that's allowing these rooms to become as contaminated and then for the counts to go up, to continue to go up, even though we do this daily intervention of cleaning and disinfection of surfaces. 6% of patient hands and 20% of patient rooms newly acquired an MDRO during the hospital stay. So patient leaves, they sample the patient's hands on discharge, they sample the rooms, and what they found was there's pretty good evidence that either the room picked up a new bug or the patient picked up a new bug during their stay. Sort of a parting gift, I guess. Frequency of high-touch surface contact. Two of these studies are a little older, but I think they're very good examples. This is a study from the US, single patient rooms, so as a preface, data in multi-patient bays might be substantially different. But in this study, what they did was they basically had somebody stand at the door and count how many people went in the room during the day. And then they tried to classify them. Were they medical staff? Were they personal visitors? Were they clinical staff and non-clinical staff, other staff? Who's going into the room? So about half the people going into the room were the nursing staff. Said another way, only half the people going in the room in a day are nursing staff. And generally, we focus our hand hygiene interventions on our nursing staff first and foremost. But half of the risk is coming from other people, in theory. So if that's the case, and John alluded to this morning, family hand hygiene, patient hand hygiene, and the non-nursing staff that come in, you may want to think about programs for hand hygiene that includes them more directly. Maybe families that come in should be given a flyer and encouraged to do hand hygiene, finding safe ways for them to participate in the process. We know that patients and staff patients and family are very hesitant to confront staff directly about not doing hand hygiene. But if the patient and the staff and the family were doing hand hygiene, that might help encourage the staff to do it as well. Nothing like a good example to help shape your own behavior, or so I've been told. When you count up and do the math, and I know you weren't told that there would be math in this, but trust me, I've summarized the data. The average number of room entries, 5.5 people per hour, a 15-hour waking day, 15.5 times, or 5.5 times 15 is 82.5. So if you ask me the over-under on how many people go into these rooms in a day, hearing the number 82 was much more than I thought it was going to be. So I thought, well, maybe this is just indicative of one particular hospital, one area, maybe it's not representative. And we'll hold that thought because there's a similar study from Adams that I'm going to talk about in a minute. But now I want to connect two pieces of information. I want to look at how many people come in and then what they touch. So the first vision of what they touch was this nice chart in the Cohen paper as well, which separated out by group, what did they touch. For visitors, which is the column on the far right, these are family members, people not having anything to do with the hospital. A third of them touch the environment only. 27% will touch the patient's skin, 17 or 18% touch blood or body fluids, and 16% of the time they touch nothing in the room. So when we think about the risk from surfaces, the visitors are typically touching lots of things in the room. They're not necessarily touching the patient, or at least they're a little bit less likely to touch the patient, but they certainly are touching lots of things. So the cleaning and disinfection in the environment of care right around the patient is very important, but other surfaces that the visitors might touch probably has some relevance for our discussion as well, because they're also going to be touching the patient's skin. Medical staff were more likely to be exposed to blood or body fluids. Non-clinical visitors and personal visitors were exposed to blood and body fluids 19% of the time. That also was higher than I thought it would be. Excuse me. But 75% of the time, non-clinical visitors touch environmental surfaces only. The non-clinical staff is the second from the right. Okay? So maybe somebody comes in and talks to the patient for various reasons, but they don't actually touch the patient, but they do touch surfaces. And those people are contributing to the risk. A nice study done by Husledge and Rutala from 2010, they had someone count the surfaces people touched when they were in the room, which I thought was a great idea. Right? So we think that certain surfaces are a problem because they're touched a lot. What does the data show? The number one touch surface in the med-surg unit, bed rails, 3.1 touches per interaction. So if a nurse comes in, they're likely, on average, to touch the bed rail approximately 3 times. You can read here some of this other detail. I'm just going to get to the math. If 82 people come in, and on average, they touch the bed rail 3 times, that means a bed rail would be touched 256 times a day. Now, even if you dispute this number, right, I think it's good to have a healthy skepticism. Any one study might not be representative, and so forth. That's a lot of touches. So even if it was half that, 125, that'd be a lot of touches. And even if it was half that again, only a quarter of it, 60 touches a day would still be a lot of touches for a bed rail. Keeping in mind that we typically only clean it once a day. So we clean it, and then it might get touched up to 300 times before we clean it again. And somewhere in there, the risk level is probably accelerating fairly rapidly. Okay, this is the Adams study. Apologize, just the hint of the reference got cut off. But they did a similar thing. They looked at how frequently surfaces were touched. And what I liked with this study, why I included, is they also did surface swabbing. They said, not only do we want to know what people are touching, we want to know how many organisms are on the surfaces that they're touching. And what they found was about 2% of the samples had MRSA or MSSA, but surfaces like the bed rail were still receiving a lot of contact. Overbed table was the highest at 37 per hour, bed rail 16 to 18 per hour, and I believe if you take the midpoint of that 18 and multiply it by the number of hours in a day, you get something like 350. So also suggesting, through a different study, different environment, bed rails being touched quite frequently. When they went to the sampling, half of the surfaces had little or no contamination. Stephanie Dancer has proposed that 2.5 CFU per square centimeter be used as a standard for cleanliness. And one of the problems we have with healthcare is that about half the time the surfaces are very clean. So those probably aren't the ones creating most of the risk. But then we have roughly a quarter that have 2 to 12 CFUs per square centimeter, and then another quarter that have more than 12 per square centimeter. So those are the ones I'm more worried about. And those surfaces most likely are the ones that correlate with higher hand contact, although they don't necessarily tell us that in the study that I recall. Okay, going on. The Clacks Study, people know what GoPro cameras are, right? Small little internet connected cameras that you can wear. Some very nice work has been done where they're starting to show what the worker is actually doing. They did 2 studies. One was specifically on hand hygiene, and one was more looking at touching of surfaces. Over 300 minutes of analysis, they found that when healthcare workers are delivering care, they touch a surface about every 4.2 seconds or about 14 times per minute. Hand hygiene occurs about 5% of the time before a colonization event. This would be touching the patient or the area immediately around the patient, but not necessarily a critical site. And 1% of the time before an infection event. This would be before an aseptic procedure or touching a critical body site, something that had an IV or a wound dressing, something like that. The workers were performing hand hygiene about 20 times per hour, or about every 3 minutes, and they averaged about 11 seconds per hand hygiene event. And I did the math here to figure this out, but I believe if I did it correctly, if they performed it for 20 seconds, which is the standard, and they did it as much as we want, which is after all of the critical events, 20% of the time the nurse spends with the patient would be spent doing hand hygiene. So one of the things we don't really talk about is what would be the impact on care if we actually got hand hygiene consistently up in that 80% range. Because now suddenly this is a big chunk of time that the staff is spending doing hand hygiene rather than care activities. And one of the reasons why we may struggle to get hand hygiene consistently that high is staff may feel the pressure. They may feel the pressure of when I do hand hygiene more, now I'm rushed trying to do other things because it's taking a lot of time to do it. And I'm not suggesting there's a good answer for it. I'm just suggesting that may be one of the levers driving why we struggle to consistently get high hand hygiene compliance. Excuse me. In the related study where they were looking at what they called infectious risk moments, where transfer of pathogens was likely, they found that with a frequency of 43 risk moments per hour of care and 56 per hour of care in the emergency settings, these moments were occurring. So where likelihood is that pathogens can be moved from surfaces to the patient. And while they talk about while the risk of transmission during any infectious risk moment may be low, the cumulative risk is probably fairly significant. 26% of the infectious risk moments involve critical sites. Pathogen transfer from outside the patient zone to inside the patient zone is likely to occur when carrying objects like mobile phones, IV bags, other supplies. And we don't always think through what the procedure should be for when people do hand hygiene when they're handling objects like that. So I'm going to vent a little bit about hand hygiene. So a nurse comes in with an armload of supplies. She picked up these supplies from other places, but she gets to the room, so she should do hand hygiene moment one before she enters the patient environment. But if she then turns around and picks up these supplies, which may be contaminated from wherever they were other places in the hospital, has she really addressed the risk to the patient? And if not, what sequence would we want? Would we want certain supplies dealt with and then doing hand hygiene? Or would we want the outside of the supplies disinfected? I'm not sure we know the answer to that, but that also, to me, becomes an interesting question. Study by Jindatha, I believe he's in Texas in the United States. They looked at worker activity, clinical worker activity, and they attempted to get a sense of just how frequently surfaces were touched and in what sequences. So, in some cases, workers touched very few surfaces. In others, they touched a lot, up to 98. The average was 13 surfaces. You can see which things they touched most frequently. Disinfection of the portable medical equipment occurred only 17 times over 144 hours. So we have a device being brought in. We have it used to treat the patient in some way, provide some element of care, and then the device leaves and goes to another area. And in this study, what they found was it's pretty unlikely that that device was actually being disinfected before it went to the next room. So disinfecting the things that are in the environment in the patient room is one thing, but we should also be thinking about the impact of portable medical equipment and how that may introduce additional pathogen risk and whether or not our policies specifically cover that. Like, whose responsibility is it? Nurses in general are trained to operate at the high end of their credentialing, which means they probably aren't the people we want spending a lot of time doing disinfection of equipment, but at the same time, if they're the ones using the equipment to provide care, we have to think about what the relationship is between dealing with a dirty or contaminated piece of equipment and cleaning it and disinfecting it so that it's ready for the next patient. And maybe you've already thought of that, right? Maybe I'm not telling you anything new, but hopefully for some of you, this is something different to think about. So this leads to the model we talk about from the Diversey perspective. In the environment of care, generally there's agreement we need to put hand hygiene at the point of care, because if we don't put hand hygiene at the point of care, it's much harder or much less likely for staff to do hand hygiene appropriately. In the same way, it may be necessary to locate disinfectants at the point of care. Now, the disinfectants will have to have certain properties. They have to be safe, something that can generally be used without a lot of PPE, and something that if the patient or the patient's family used, we wouldn't have a lot of issue with. So highly hazardous products probably are not a good fit for this sort of model. Pre-wetted disinfectant wipes offer one opportunity to do this. There might be others. This is an example of a hospital room that's using the practice. You can see on the wall they have a container of disinfectant wipes, and the circles in blue indicate various surfaces that might need to be disinfected after the medical staff delivered their care. And if you were looking for it as a model, it would look something like this. So when would you want to train staff to do the disinfection? Before placing food or drink on the overbed table, because that's probably contaminated. Before and after doing aseptic procedures, if any surfaces got contaminated, or we're going to have the supplies put on them. After any procedure involving feces or respiratory secretions. After bathing within the bed space. And after any object used on or by a patient or resident touches the floor. So a staff member is providing care, they drop something on the floor, and they pick it up. Do they know, are we confident they would disinfect that before bringing it back into the environment of care and using it with the patient? So this is the basic concept. And we've been using this now with some facilities in the US. And in the next year, we're going to start to see some papers published from their results. But so far, they're showing improvements in certain infection rates. Now, before I talk more about that aspect of it, I want to just go with, is this a new idea? Like, are we really brilliant people? And the answer, of course, is no. Everybody that does research builds on the mountains of evidence that were there before them. And we found 3 different studies that talked about this in various ways. The Ali study from 2012. Regular wiping with antibacterial wipes could be a cost-effective means of maintaining low numbers of bacteria near to the patient. I like that. To keep the bacterial population in check, the Attaway study, bed rails likely would require bi-hourly cleaning. I'm not sure I'd sign up for bi-hourly cleaning, but I appreciate the sentiment, which is more than once a day. So thinking about how frequently it's necessary to do this probably involves studies that require frequent sampling, so you get a sense of how are the care activities impacting the levels of bacteria. There have been studies done on airborne populations of bacteria, and typically in the mornings there's a lot of activity around the patient. Perhaps sometime after that, but before lunch, certain surfaces should be wiped down. Hypothesizing. And apparently they put some red lines on there. Good. 2 specific things when thinking about selecting disinfectants. The Rotala paper from 2014 talked about 14 properties for an ideal disinfectant. What would you want your disinfectant to do if it could do everything you needed to do as clinical staff? So I took the 14 properties and sorted them into 3 groups because I think it makes it a little easier for discussion. There's factors related to the efficacy of the disinfectant, factors related to the safety, and factors related to making it convenient to use. These are all important elements in determining whether or not a disinfectant will work for you and is likely to be used by staff. When I take the major chemistries that are used within the industry and I map them, and it looks like my dots drifted up for some reason. Everything is 1 line lower. But across the chemical types, what you should see is that green is not present for everything in a column, meaning that there's no one chemistry that does all 14 of the properties as well as we'd want it to. And that, I think, leads to a discussion around what are the trade-offs in picking a particular disinfectant. Disinfectants will likely involve some compromises. Some that have the best efficacy might not be very safe to use around patients. Others that can be used around patients may or may not provide the efficacy you desire. Some may represent significant risks because of odor or surface compatibility. Those are all factors that have to be considered. But if you're interested in this topic, we just wrote a commentary on it that got accepted for publication in a journal in the US, Joint Commission of Journal on Quality and Patient Safety, and it probably will be published in the next 60 days.